Thank you so much, Helen, and hello, both to new and known colleagues and friends. Um, there are six of us presenting today, but we represent hundreds of people who have supported us. So thank you to those of you. As Helen says, my name's Alistair Hay. I'm a practicing GP in North Bristol, and I'm a professor of primary care here at the university. And I have led the University of Bristol's Centre for Academic Primary Care Infection Group for the last 24 years. Our research is mostly applied health. It's quite practical research, and it's always been PPI informed, that is, patient and public participants. And it's increasingly now PPI co-designed. And it's characterized by its interdisciplinarity, collaboration, high quality, and real world impact. And I'd also like to think we have quite a lot of fun along the way. Although I'm employed as a university academic, I've always felt particularly accountable to the NHS, to my colleagues and our patients. If you were to sort of crack me open like a stick of rock, you'd find NHS written all the way through me. So this is also your opportunity to hold me and our group to account. The group's main aim is to improve the management of infections and the use of antibiotics, and I expect increasingly antivirals in primary care. And this slide represents how we conceptualize our work. And you will be seeing, I think, a few familiar logos for studies. Again, thank you if you have supported one or more of these. And what I'm going to do now is walk us through this slide, and then each of the presenters will be talking about a particular aspect or aspects of this slide with respect to specific studies. I just want to say that it all looks very neat and coherent now, but it wasn't always like this. And this structure is very much with the benefit of hindsight. It's really only emerged that this is the way we think about our research in the last few years. So I'll begin. And what I'm going to do then is really bring the kind of situation to life. At the right-hand end of the slide here, we've got antibiotic resistance and we've got patient outcomes. These are the key endpoints for everything we do. But the pathway begins right at the beginning when all of us will get infections. I can't think of a single person who won't have. If you've never had an infection, please let me know now, because I'd very much like to research you. But seriously, all of us acquire infections, and then we're all of us responsible for transmitting them. And we will be talking about a couple of studies that we have done to try and make sense of that part of the pathway. We then, all of us, become unwell. And it's my belief that we have a responsibility to look after ourselves and to only make contact with the medical services when we really need to, in order to preserve accessibility for those who need healthcare most. And so all of us, I think, are obliged to look after ourselves. So there's a couple of studies, you may recognize these logos as well, that I'll briefly talk about in terms of supporting self-care. The decision as to whether we consult the NHS, and usually that means contacting our GP, is a really difficult one. And Dr. Cabral will be talking about some research that we have planned and that we have done to look at how best to support people, parents and carers making that difficult decision. And this is really important because for every one person that currently is seen in primary care by GPs, nurses, pharmacists, and paramedics, there is probably at least another 10 or 11 people with infections who have not chosen to seek help. if that proportion or that number that have chosen not to seek help were to seek help, it would have huge implications for workload and sustainability in primary care. And of course, none of us can escape the fact that the NHS is in the news at the moment. It has been for the last few years, with one of the main issues being lack of capacity. So preserving the capacity that we have in primary care, I think, is a key responsibility, and particularly for those of us managing and researching infections. Once you've made the decision to attend, there is obviously the process by which the clinician you see will make a diagnosis and then start to think about and consider treatments and therapies. And that is a complicated part of the pathway. Clearly, there are patients who do need antibiotics, and we do need to identify those. And for example, the duty study was set up specifically to identify children with urinary tract infections in primary care. Again, thank you for the many hundreds of you that supported that study. OSAC was one in which we demonstrated that oral steroids do not help people who have presented to primary care with chest infections when they don't already have asthma. So we've done some work in that arena as well. And we may turn to other testing to help us make the decision about antibiotic prescribing. And Dr. Emily Brown will be talking about both the rapid immune and rapid test studies. These are point of care test studies which are seeking to help that prescribing decision. Many of you will remember the target study, the outputs of which included the star wave algorithm and the Care for Your Child with Cough leaflets. And those really are about helping clinicians use the information that is already available to them in the consulting room to help them make that prescribing decision. Once an antibiotic has been prescribed, it of course goes to a pharmacist to be dispensed. That's an area that I think deserves more research, and I think our group could do more in that space. And then, of course, the patient will make a decision as to whether they collect that prescription and then whether they consume it. The consumption decision is a difficult one to measure. We usually rely on self-report, but we can at least understand whether the patient has collected the prescription. And you'll be hearing from Dr. Joanna Fodor and Dr. Polly Duncan, who'll be describing a study around delayed antibiotic prescribing. And then, of course, once consumed, an antibiotic, particularly an oral antibiotic, is then distributed once it's swallowed throughout the human body. It will lead to antibiotics being in the gut, in the bloodstream, in the urinary tract, in the respiratory tract. So although its intended target might be a urine infection, it will also be affecting germs throughout the body. In other words, antibiotics are indiscriminate and they lead to resistance throughout the human system. And that's one of the key things that we're seeking to reduce and contain so that we can.
Sorry, we seem to have a problem there. Alistair, you've frozen? I'm just wondering, Alistair, if maybe you can...
I'm now going to become Ashley Hammond. So my computer's just decided to do a restart. What perfect timing. Can you imagine? Where was I? I think indiscriminate use of antibiotics and then patient outcomes being the key endpoint. So I'll carry on if that's all right, Alan. And one of the things I'm proud of is that we in Bristol have led some of the work describing and quantifying the relationship between the use of antibiotics in primary care and resistance. And I'm very pleased that we've got Dr. Ashley Hammond with us today, who's going to talk about that work. So back to acquisition and transmission. And in the last couple of minutes that I've got, I want to briefly mention the AFRI-C study. This is a study that is near completion, which is seeking to understand whether HEPA filters, these are high efficiency particulate air filtration units, can interrupt airborne transmission of infections within care homes between to the benefit of residents. These are filters that can remove and have been demonstrated to remove from the air all the microbes that we understand are important to human health, right down to the flu virus. So there's every reason to think that they could benefit human health. And the study that we've just done has randomized 91 care homes and just under 1,200 residents to either usual infection prevention and control or usual infection prevention and control plus air filters in individual bedrooms and in communal areas. Primary outcome being the number of symptomatic respiratory infection episodes in residents, but you'll see there's quite a few secondary outcomes as well. Recruitment's gone extremely well, and we've reached, or more than reached, our target number of follow-up days in residents. That will be published, we hope, in the coming few months. We're just preparing the paper for submission. We're hoping the BMJ might be interested. And then lastly, self-care. Pitch the Duck, that takes us back quite a way. Some of you may remember Pitch. This was a study of children who experienced really discomforting symptoms of fever and pain. For fever, Pitch was a study looking at whether 2 antipyretics are superior to 1, so that's paracetamol and ibuprofen. And the parents in this study were absolutely wonderful. They supported their children wearing this little logger, which measured the child's temperature every 30 seconds and gave us really detailed information about the temperature. And you can see that we were able to demonstrate that the use of both antipyretics is superior to 1 on its own for childhood fever. That led to a very nice publication in the BMJ, but more importantly, a change in NICE and Royal College of Pediatric and Child Health guidelines on the use of antipyretics. And then finally, this poor young lady has an ear infection. Middle infections are very painful. They stretch the eardrum, and it's the eardrum which is the site of the pain. And Carl here is sort of in sympathy with our friend who's got this painful ear. Carl was the mascot for this study. And it occurred to us that an anesthetic eardrop might prove useful. And indeed it did. So we demonstrated that it was able to reduce pain at 24 hours and also reliance on antibiotics, reduced antibiotic consumption at day 8. That led to a nice publication, but also of great interest to us, it led to change in NICE guidance. And NICE now recommend that an anesthetic eardrop can be considered for children with middle ear infection who don't require an immediate antibiotic. That in turn has been incorporated into the pharmacy first treatment pathway, and that is leading to quite a rapid increase in the use of anesthetic eardrops in children. So thank you for your attention, and I'm now going to hand you on to Christy Cabral. Thank you, Christy.
Thanks, Alistair. So I'm going to talk a little bit about the primary care attendance and focusing here specifically on children with cough, which is where we've done most of our research. Next slide, please. Oh, I can move them on, can't I? Forgive me. So we did some research quite a while ago, part of the Target project, where we were trying to find out why parents were coming in with children with a cough when they perhaps weren't that well. You can see here that there are things that we kind of expected to see, so the kinds of symptoms that you might expect, like fever or pain or kind of chesty sounding coughs. But there were also some things that worried parents that weren't necessarily that expected from a clinical point of view. So they worried about if it's so bad their child can't sleep, or if it was interrupting their feeding, particularly with very young children, that it might somehow impact on their development and growth, which isn't, really the case, but that was the kind of thing that was going through parents' minds and often went unspoken in consultations. And you can see here on the right a lovely graph. This is a piece of work that was done by some colleagues of ours, looking at how severe the patients rated the child's illness compared with how severe the clinicians rated the children's illness and this is for a large cohort of children under 12 who came to see their GP. And you can see here that the parents were generally thinking things were much worse than the clinicians thought they were. And so we felt there was something that could be done here to sort of try and take those children who are less unwell and encourage more self-care for those children and reduce the burden in the of consultations. I did another study, Conquer we called it, and this was looking at where did the parents' ideas about what needed to be seen by doctors and what might need antibiotics, where did those beliefs come from? And we could see that it was really coming from what was being said in the consultation. So it's this clinical communication. And it wasn't really that clinicians were giving clear kind of, if these symptoms, then you should bring them in, or then they need antibiotics, because in a way there isn't really clear evidence linking those symptoms to either of those needs. But what was being said in the consultations, and we videoed some of these and looked at what was actually said, clinicians, when they were making a viral diagnosis, they would kind of link it to lower severity and things not being too bad. So they quite often gave it a virus, saying it's just a virus, was sort of classic thing, or it's a virus, they're not too bad, that kind of thing. But when they prescribed antibiotics, interestingly, they never gave it a bacterial diagnosis, but they did link it to things being more severe, and they also linked it to specific symptoms. I've included a few quotes there. I won't read them all, but the classic ones were if there was any kind of chest sound, which they could hear with a stethoscope. Now, that means that in order to find out whether or not they need antibiotics, you've got to take them to somebody who can listen to a chest with a stethoscope. If there was yellow phlegm, if there was temperature, that kind of thing. These sort of beliefs that were being perpetuated amongst parents and in the community and leading to consultations were coming about as a result of the communication that was happening in the consultation itself. And there was also something else that was really relevant to managing children, which was this kind of wider social constructions of the need to keep children safe and the responsibility of the adults concerned towards keeping children as safe as possible. It really, our society tends to kind of view anyone who allows children to be put at risk as being, doing something horribly wrong, which is very understandable. So the mothers were talking about, in terms of children, you can't be too careful, really. You just always like to rule it out. There's not some kind of infection that needs antibiotics. And the GPs similarly, so saying, well, as a result of not taking antibiotics, a child became very unwell, it's very difficult justifying holding it back, right? So for the mothers, sometimes they're consulting almost to demonstrate that they're doing what they ought to do on behalf of their child, not even necessarily because they're that worried. And the GPs, when they come to prescribing, they're prescribing if they can't definitely rule out a need for antibiotics. And both of those things push us towards higher antibiotic use than is perhaps needed. So what we did, and this is the one that got away that we had in the running schedule, we co-designed a website and leaflets with 4 different parent groups from different backgrounds. We had South Asian, Somali, white British, all low socioeconomic status, and an Eastern European parent group. And we talked about all of the different symptoms that they were worried about, and we gave them relevant information to help them understand and interpret those symptoms. And then we also took the NICE traffic light guidance and adapted it for parents consulting. So the NICE traffic guidance is for clinicians to decide about how to treat children. But what we did is we took it to parents and we sort of talked through how to make it useful enough for them to make a decision about whether or not to consult. And we then did some consultations with clinicians, and we also put together 2 funding applications to try and get a study to evaluate whether this could safely reduce parental consulting. both of which were rejected. And it really came down to this concern about safety. That it was giving parents very specific advice about when to see the doctor was characterized as a double-edged sword. This was a metaphor that was used by several clinicians that we talked to. They were worried that if they gave very specific advice to parents, they could misinterpret it in two ways. They might either misinterpret it and be consulting more as a result, which would add to the workload and of already pressured services, or even worse, they would misinterpret it and not bring a child in when they needed to be seen, and missing a sick child with terrible consequences for all concerned. And so it was really this not really wanting to risk the safety of children, even though this was a trial that would be looking at, is it safe to do this? That meant that this one never actually got done. Although we did produce, as you can see, these materials in a nice shareable format, and they are available via the Public Health England resources to try and support lower antibiotic prescribing. Okay, I'm going to hand over now to Emily to talk about what happens in the consultation room.
Hi, everyone. I'm Dr. Emily Brown. I'm a GP and researcher in the infection group here in Bristol. And my research focuses on the use of point-of-care tests for diagnosing infections and guiding antibiotic use in primary care. So today I'll be talking about two of the studies that we're currently doing in this area that we can see on the slide here. So that's the rapid test trial and the rapid immune test study. So firstly, what are point-of-care tests? Point-of-care tests are, in essence, tests that can be used in primary care at the point of care. So this means that the patient or a sample from the patient doesn't need to go to the hospital or the laboratory. The test can be done there and then in primary care. This means that the results can be provided to the clinician and the patient in real or near real time. This is a really topical area at the moment. Point-of-care test technology for infection diagnostics is rapidly evolving, and lots of new tests are being developed. And this is very exciting, but it also presents challenges in understanding the potential benefits and potential risks from these new tests. So today I'll be focusing on point-of-care tests for diagnosing respiratory infections, but just to note that they can be used for other infections as well. So thinking about our central research question here around antibiotic resistance, AMR, could point-of-care tests help tackle AMR in primary care? We know that around 80% of antibiotics used in the NHS are prescribed in primary care, and at least 20% of these prescriptions are unnecessary. And this is especially true for respiratory tract infections, which are the infections most associated with inappropriate antibiotic prescribing. And as we've heard today, and we'll keep reiterating, antibiotics only work against bacteria and not against viruses, yet they're often given for respiratory infections which are commonly caused by viruses like sore throats and sinus infections. It's really difficult for clinicians in primary care to know if respiratory infections are caused by a virus or by a bacteria. And we know that symptoms and signs aren't very good at helping us know this. And quick diagnostic tests are not currently widely available to help primary care clinicians with this. So a potential solution could be rapid point-of-care tests. These tests might help patients and clinicians know if they have a viral infection and so don't need antibiotics. However, point-of-care tests for diagnosing respiratory infections are relatively new, and there isn't much research yet about whether they're helpful, especially in primary care. For example, we need to know if the tests are accurate, if patients are happy to use them, if using them actually does reduce antibiotic use, and importantly, doesn't also worsen patient outcomes. And of course, we need to know if they're a good use of NHS money. We also need to understand how they could influence clinical decision-making and where they might best fit in current consultation pathways. Also, what impacts might they have longer term? Could they medicalise minor illness and increase health-seeking behaviour in an already overstretched NHS? So there are lots of questions, and we need well-designed independent clinical studies to help address these questions. And we believe that we need these before point-of-care tests are introduced into clinical practice. So I'm going to now talk about two studies that the infection group are leading to help start answering some of these important questions. Firstly, I'm going to talk about the rapid test trial, which is a large randomised control trial that we're currently analysing the results of. The point of care test being assessed in this trial is called the BioFire film array. It's what we call a microbiological point of care test, which means it's testing for the presence of specific bacteria and viruses. The trial recruited participants from GP practices in southwest England. Participants were then randomised to either have their usual care or to have the microbiological point of care test. Patients had a combined nose and throat swab taken, so that's a bit like doing a COVID test. And then the BioFire film array was used to analyse the swab. It uses a technique called PCR to detect 19 of the main respiratory viruses and 4 atypical respiratory bacteria. It doesn't test for what we call the typical respiratory bacteria, which are the most common causes of bacterial respiratory infections. And it takes about 45 minutes to get the results. So this is a large trial with lots of objectives, and I'll just mention the key ones here. The primary clinical objective is to investigate if use of this point of care test can reduce same-day antibiotic prescribing in children and adults presenting to primary care with respiratory tract infections. The key secondary clinical objective is to investigate if the use of the point of care test changes participants' symptoms. And this is through measuring participant-reported symptoms and their severity on days 2 to 4, and also the duration of their symptoms. We're also investigating the mechanisms by which any changes to antibiotic prescribing occur. So we're, for example, investigating specifically if detecting a virus reduces same-day antibiotic prescribing. In the trial, we're also interviewing clinicians and patients to explore their views on the point of care test and how it could influence treatment decisions and future consulting. So we had 8 BioFire machines available to use, and we recruited from 16 different GP practices centred around the Bristol area over the last 2 winter seasons. So we ran the trial at 8 sites per winter season. And we can see these sites where they are on the map on the slide. And the sites varied in terms of their social demographics and their rural versus urban location. This graph shows our predicted recruitment in yellow and our actual recruitment in green. So we can see that the trial recruited very well, and it completed recruitment in April 2024, which was 5 months ahead of schedule. So where we're at now is that the data are currently being analysed and results will start to be published in the next few months. So look out for these. Now I'm going to talk about a different study with a similar name, and this is the Rapid Immune Test study. Rapid Immune Test is a smaller early stage study assessing the feasibility of using a different type of point of care test for upper respiratory infections. So that's things like sore throats and sinusitis. The point of care test that we're assessing in the study uses a small finger prick blood sample to measure proteins from the patient's immune system. And it uses this to indicate whether the patient's immune system is reacting against a virus or a bacterial infection. The test that we're using is called Febridex. There's a picture of it on the slide. And it's a small single-use lateral flow assay. So it's a similar mechanism to the COVID test, but it uses blood rather than liquid from a swab sample. It takes about 10 minutes, and it measures a protein called CRP, which is generally raised in bacterial infections, and a protein called MXA, which is generally raised in viral infections. So in the Rapid Immune Test study, we're assessing the feasibility and potential value of Febridex for children and adults with upper respiratory infections in primary care. And like I say, that's things like sore throats and sinusitis. And we're also assessing whether Febridex changes what healthcare staff think is causing the infection and whether antibiotics are needed. We're interviewing patients and healthcare professionals to understand their experiences with Febridex. And lastly, we're assessing the diagnostic accuracy of Febridex by comparing it to swabs sent to the laboratory for PCR. So we're currently recruiting patients to this study. We're really excited. Recruitment started a few weeks ago. And we're due to complete recruitment in 3 to 4 months. So thank you very much to everyone who's involved with that at the moment. So that's a whistle-stop tour through some of the work we're doing at the moment around point-of-care tests. Looking forwards, the use of point-of-care tests for infection diagnostics and guiding antibiotic use in primary care is a rapidly evolving space. The technology advances are really exciting. However, high-quality evidence is needed to understand whether point-of-care tests do bring benefits. Are they accurate? Are they safe? Do they reduce antibiotic use? And are they cost-effective? So we, as the infection group, and along with the wider research community and our collaborators, will continue to work to gather this evidence. And we're looking forward to the results of the studies I've discussed being published in due course. So please do watch this space. So I'll now hand over to Joanna and Polly.
Thank you. So the next project is being co-led by myself, Joanna Fodor, a pharmacist, and my colleague, Polly Duncan, a GP. This project is linked with a surveillance study called AvenCap GP2. So the project is looking at delayed antibiotic prescribing in primary care. But first of all, what is it? So delayed prescribing of antibiotics is when a healthcare professional prescribes an antibiotic but advises the patient not to take the antibiotic straight away, to wait for a couple of days, and to only take it if their symptoms are getting worse. There is some evidence from randomized controlled trials that delayed prescribing reduces use of antibiotics, but there is a lack of evidence of this in a real world setting. And it's quite difficult to look at this issue with routinely collected data, because GPs might be telling the patients to delay taking the antibiotic or not to take it at all if their symptoms don't get worse. But more often than not, they do not record this in the patient's electronic GP record. So the aim of our study is to look at the use of delayed antibiotic prescribing in the UK general practice. So we want to understand how often is delayed prescribing used, what type of healthcare professionals use it the most, for which patients and infections, and importantly, does it work? And by this, does it reduce the possibility or the chance of the patient collecting the prescription from pharmacy? And if this is found, this delayed prescribing could be used as a powerful tool to reduce antibiotic use and subsequent antimicrobial resistance. So our project will take place in 6 GP practices, serving different types of populations in Bristol. There are about 120,000 patients registered with these practices. And now I'll hand over to my colleague Polly to tell you about how we plan to do this.
Thanks, Joanna. So as part of a surveillance study, as Joanna mentioned, AvenCap GP2, we set up a prompt to appear every time an antibiotic is prescribed. So the prompt appears for children and adult patients and simply asks, is this a delayed antibiotic prescription? The response, yes or no, is recorded and coded within the patient's electronic GP record. The prompt has actually been running in all 6 practices for a 2-year period. And we provided training to clinicians in the practices about every 6 months, encouraging them to engage with the prompt. Our plan is to extract data from the electronic GP records, including data about the antibiotic, about the consultation, such as the type of healthcare professional and whether it was a face-to-face or a phone consultation, the clinical diagnosis, and then lastly, patient characteristics such as gender, age, ethnicity, deprivation decile, number of long-term conditions. Our hope is that we'll be able to link these data with dispensing data from the NHS Digital Electronic Prescription Service, or EPS. This will allow us to answer our question, does delayed prescribing reduce collection of antibiotics? we're really excited by this project and its potential sort of impact, but it's proving quite challenging to obtain the dispensing data. Finally, a bit of a shameless plug. So as part of the AvenCap GP study, we co-developed a short film called Why Take Part in Research with members of our patient and public involvement group. It's only about 2 minutes long. It purposefully includes a diverse range of people, so different ages, genders, ethnicities. It's available in English and also in 10 other languages. And it's been really popular with our study participants. Lots of people have sort of fed back that they didn't really know anything about research before taking part in our study, and this short film was a useful kind of introduction. So we're keen for others to use this film, so please feel free to watch it and use it in your research. So now I'm passing on to Ashley.
Thank you, Polly. Hi, everyone. I'm Ashley Hammond. I'm a research fellow and also one of the co-leads of the IPAP UTI programme that I'm going to be talking to you about now. So I'm kind of taking us towards the end of this pathway now to talk about the work that we are doing to tackle antibiotic resistance, or AMR. Of course, this is one of the key elements of this pathway that we are trying to prevent. So tackling AMR has been, I'm sure many of you know, a public health priority nationally and globally for many years now. And that's largely because of the significant threat that it poses to human health and medicine. And from a patient perspective, AMR infections can last longer, they can become more severe, and they might require multiple antibiotic courses. All of this reinforces this development and persistence of AMR, of course. So what are we going to do about it? Well, there have been many observational studies which have demonstrated this link between antibiotic prescribing in primary care and AMR. And I'm just showing you a few examples now of some of the published research in this area from within the CAP C infection team. We have a very strong reputation in this field, and we've made quite a significant contribution so far, I think, to our understanding in this area. And because of what we know from these studies and many other similar studies from other research groups, policymakers who are looking to tackle AMR, I think, need to ask themselves two questions really. First, are these results reliable? And two, what should be done about it? So I think, firstly, these results are likely to not be that reliable, just because the methods used mean that there could be other unmeasured factors that are contributing to some of the changes in the associations that we see within these observational studies. And secondly, in terms of what should be done, I don't think anyone really knows what to do next. So hopefully that's where we come in. So the IPAP UTI programme, it's a 5-year NIHR funded programme grant, and essentially it's an antibiotic prescribing intervention to try and reduce AMR in urinary tract infections or UTIs in primary care. So I'm one of the co-leads of the IPAP UTI programme along with Alistair Hay, but it is very much a large collaborative project between ourselves and the Bristol team, the UK Health Security Agency and NHS England. So I'm sure most of you know that UTIs are one of the most common infections that we see in primary care. They mostly affect women, but also men. Symptoms can be pretty unpleasant. What typically happens when someone experiences UTI symptoms is they take themselves off to the GP. The GP might then ask them to submit a urine sample so that they can send that to the lab for testing. But most of the time, if you're young and otherwise healthy, this is your first UTI, the GP won't bother to ask for a urine sample as per the NICE guidelines, and they will prescribe antibiotics to you empirically, so without knowing at that point whether the patient has an infection or not. So I think what's important here is that GPs and prescribers are often very much in the dark when determining how to manage a UTI. And I think this is really the part that we want to optimize in the IPAP UTI programme, to try and make sure that patients can receive the most appropriate antibiotic to them within the current primary care setup. So IPAP will involve a series of 3 randomized controlled trials across integrated care boards, or ICBs, in England. For those of you who don't know, an ICB is it's an NHS organisation that is responsible for the health services within a more local population. So there are 42 ICBs in England. 1 ICB will be recruited per trial, and we will be randomizing all eligible GP practices within that ICB to either receive the antibiotic prescribing intervention or continue with usual care. Why are we doing this? Well, to our knowledge, this has never been done before, so it's a global first. As far as we're aware, no one has done a randomized controlled trial with AMR as the primary outcome, which makes it very exciting and also very important. We want to promote antimicrobial stewardship in primary care that's based on local AMR surveillance data. And of course, we want to improve outcomes for patients with UTIs. The trials will be across ICBs in England, where the AMR need is greatest. And we will be using routinely collected AMR surveillance data from the UK Health Security Agency to determine ICBs with an AMR need. And an example of an AMR need in this case would be an ICB reporting AMR against a commonly used antibiotic to treat UTI, which is consistently high or increasing, for example. And we're also using the UKHSA routinely collected data set to monitor and report our trial outcomes too. So these maps that you should be able to see now were generated using this UKHSA routine surveillance data set for AMR and UTIs, and also national dispensing data, which we obtained via the UKHSA too. So you've got dispensing data and AMR data here. The maps on the left show the rate of dispensed trimethoprim, just using that as an example. It's one of the first choice antibiotic treatments for UTI. So it shows the rate of dispensed trimethoprim per 100,000 registered patients for each of the 42 ICBs in England from April 2018 to March 2023. Both of these maps are moving forward quarterly according to financial year from 2018 to 2023. The map on the right shows the percentage of E. coli confirmed UTIs, which is E. coli is the most common cause of UTI, which were resistant to trimethoprim. What I think is important about what these maps are showing is that there is some variation across some of the ICBs in both dispensing and AMR against trimethoprim. And I think that really is important because it illustrates why we should be taking into account this more localized dispensing and AMR data when we consider how UTIs should be optimally managed. And that might look slightly different in slightly different areas. And I think that's very much one of the overarching aims of the IPAP UTI programme. So this map shows trimethoprim AMR across the 42 ICBs in England for just the last financial quarter of 2023. It's just there for an example, but what we can see here is that some ICBs have darker shades of green, meaning that trimethoprim resistance in those ICBs is higher. Therefore, they represent a potential AMR need in those ICBs for this trial. What we will then do is make contact with these potential ICBs and work with them if they're interested in taking part in a very much co-designed approach to develop and refine an antibiotic prescribing intervention that works for their ICB and the GP practices within it. So we would contract with the ICB then, and we would randomise, we'll randomise all eligible GP practices to either the intervention group or just to continue with usual care. The intervention will involve a switch from an antibiotic where AMR in that ICB is high to instead using an antibiotic which has low AMR in that ICB for the management of UTI to see if that can bring down, if using that antibiotic less can bring down that AMR. So exactly how this intervention is delivered to GP practices that are randomised to the intervention group can vary and will vary throughout the 3 RCTs, but it could include elements such as electronic prompts to the prescribers to remind them to use the alternative antibiotic instead if they feel that it's clinically appropriate, or things like visual aids such as posters and web pages, etc. So at the moment, we've recruited our first ICB, and in the last month, we have randomized approximately 2.6 million patients within it. So that's very exciting. And we are also in the process of setting up our second and third ICBs for trial 2 and 3. So please definitely do watch this space. It's a very exciting space to watch. As I say, this is very much a global first, so hopefully we'll have some very interesting results to share with you all very soon. Okay, so I am tasked now to summarize and bring all of this together that we've been talking about today. So I'm going to take us back to this diagram showing the journey through managing acute infections and using antibiotics in primary care. I hope that you've gotten a sense that our research group have done and are still doing lots of really important research to try and improve lots of these different aspects of infection management in primary care. Our work truly is very interdisciplinary, and I think that allows us to be more ambitious and reach that little bit further. And part of the foundation of that is the very much the co-production and the co-designed approach that we take within our research, and particularly with the links we have with our PPI groups. It's a complex pathway, as you can see, involving lots of different components, which as we flow through it can ultimately lead to antibiotic consumption and AMR. And this is what we want to try and both optimize and minimize, I think, as much as possible. What I think we ultimately want is for patients to be able to access the right care that they need, whether that be being signposted to effective self-care treatments, accessing the most useful diagnostic tests to allow clinicians to make the best treatment decisions, all whilst limiting the excess need for antibiotics. So making sure that the patient receives the right antibiotic when it's needed. I'm sure you will all agree that it's not an easy task, but I think me and we within the team are very fortunate to be based within an institution that has such a strong reputation, both nationally and internationally, for the impactful research that is done in this field. So we are definitely amongst great minds, I think, here in Bristol. So on that note, I'm just going to conclude by saying thank you to everyone within the team, not just those who have presented today, but for all the really important research that you have done and that you continue to do. And thank you to finally to everyone for coming along today to hear all about the incredible work that we have done so far. So thank you. And I'm now going to hand you back to Joanna to take us through the Q&A.
Thank you, Ashley. I'm just going to try and take them in order. So we've got a question from Elizabeth. I think Alistair probably partly answered this in the chat. So she was asking, well, Alistair and Christy, sorry, about Christy's presentation. So that Chris is describing how parents and clinicians rule out. And she's asking how could this be shifted to a rule-in approach? Any evidence to support this approach?
I'm happy to take that one if you like, Joanna.
Okay.
So thanks, Elizabeth. Ruling out important infections and complications is a lot easier in primary care than ruling it in. Most of the patients we see are relatively well, and we can be, in many of them, reasonably confident that they're not going to go on to become very unwell. But the real challenge, as Christy was highlighting, is detecting that rare but an unfortunate situation where somebody's actually severely ill and they're on a trajectory to perhaps requiring hospital care and serious intervention. That's really tricky in primary care. I think that our colleagues in Europe are leading the way. I saw a very interesting presentation from a Belgian group at a recent conference, which was seeking to merge the best of what we've used in the past in terms of tools. And I'm following that study with great interest. I think it's going to be published pretty soon, I hope. I'm afraid I can't recall the name of the authorship group at the minute, but I'd be happy to flesh that out a little bit. So they, I think, are as close as anyone is at the moment to this rule-in ability to rule in. So thanks, Elizabeth. It's a tricky one.
Thank you. I'll move on to the next question from Christine. She's asking, the Scandinavian countries have been using CRP for decades. Why do you think that evidence is still lacking? Not sure who wants to take this one.
Yeah, go on, Emily.
I'm happy to. Okay, so thank you for that question, Christine. And I completely agree. There is a lot of evidence for the use of CRP point of care tests in certain cases, and they've been around for quite a while now. So, for example, here in the UK, CRP point of care tests are recommended by NICE for patients with a suspected pneumonia. In practice in the UK, CRP point of care tests aren't used very much. So I think that in itself is an interesting question to explore. But I recognise our Scandinavian colleagues are certainly ahead of us in that area. I think our focus and interest from the research point of view is around the fact that point of care technology is evolving, rapidly advancing, and we need evidence around those new types of point of care tests. So that's like the point of care test I described when I was talking. So those that are measuring multiple different biomarkers, so CRP and another immune marker, for example, which might increase the accuracy of those types of point of care tests. There's some concerns that perhaps CRP alone isn't accurate enough. And then also the other types of point of care tests, so microbiological point of care tests, measuring the presence of multiple different viruses and bacteria. And we really have very little evidence for their use in primary care. So yeah, thanks for your question.
Thank you, Emily. Next question is from Merlin. He's asking, regarding does delayed prescribing work? Then we already know that it does from the Cochrane review. Also, I think it has become more difficult since the advent of electronic prescribing. Really look into that. I'm going to start probably try to answer answer the comment and the question, or partly. So in terms of delayed prescribing, yes, we obviously are aware of the Cochrane review, but I think the work is focusing on the actual collection of the prescription from pharmacies. And as far as we're aware, there hasn't been any work done to look at this part of delayed prescribing. I'm not sure if Polly or Alistair want to chip in with anything.
Yeah, I think it's a good point. I think the Cochrane review focuses on trials, and here we're looking at creating some evidence in a real world setting. So I suppose that's the difference with our study. The follow-up bit, I couldn't quite follow about electronic prescribing and how that makes things difficult in terms of delayed prescribing.
I wonder if Merlin might be referring to the fact it's slightly more clunky, because in the good old days of paper, you could print the prescription, sign it, hand it to the patient or parent or carer and say, hang on to this for now. Don't use it unless certain circumstances happen. It is possible with electronic prescribing to do it. And the way to do it is to issue the prescription, but not send it to a specific pharmacy. So I think there's something like any pharmacy, I forget the precise terminology, and then you copy the unique code from the prescription and then you can text that to the patient. So it is slightly more clunky, but they can then take that code to any pharmacy, and the pharmacy will know exactly which antibiotic is to be dispensed. So it's possible, but it is slightly less simple. Anyway, maybe Merlin's question was slightly different to that. So I hope I've anticipated correctly, but if not, do let us know, Merlin.
Thank you. I think we might have time. Yeah, so he said, sorry, I've got a comment from Merlin saying, thank you, Alistair, that was right. Thank you, Merlin, for that. I'll move on to the next question from Kathleen, and she's asking, is the technology available to do point of care urine microscopy, which if negative could rule out UTI in most patients? Ashley, do you want to take this? Or
I feel like this is probably more for Alistair.
Okay, well,
I'm not sure about the point of care tests.
I'll have a go with this one. So thanks, Kathleen. I mean, there are GPs who still do wet film microscopy, where you can take a fresh sample of urine and look at it in the microscope in your practice and determine the presence of things like white cells and red cells. There's also a test called FlexiCult, I believe. I hope I've got the name right, in which you can put a drop of urine into a well, and the FlexiCult allows the bugs in the urine to grow up, and over a period of about 18 hours, you can identify which bug and to a certain extent whether it's resistant or not. There's a lot of technology coming on stream quite quickly. There is the Longitude Prize winner that has developed rapid point of care testing for urinary infection. There's also a sister company called Utilizer that can do something similar in a matter of hours. So this is as Emily was saying, this is a sort of rapidly evolving space. And I think your question is really important, just to sort of come back to it, because there's a very high proportion of patients who present to primary care with what look like typical urinary tract infection symptoms, but who actually don't have a UTI. And so a rule-out test would be really valuable, I think, in primary care. And if properly used, it could dramatically reduce prescribing almost overnight for this problem. So thank you for that question.
thank you. I think this is what we had time for in terms of questions, and we'll be in touch anyhow. I've seen one more question from you, but I'll just hand over to Helen for one more slide before we finish.
Right, so yeah, so thanks everyone, thanks to all of the panelists for your fantastic presentations. And this is just a quick list of ways that you can keep in touch with us via our social media, newsletter, our website. And if you want to keep up to date with our forthcoming webinars, you can do so on the events page of our website, obviously through our social media channels as well. All right, thanks very much, everyone. Have a good day.